Next up, we have Stryker. We have Dr. Schliffka. He's coming back to us. This is his second time on the show, right?
Yes.
Yes, repeat performance. And we are going to be showing off the SpineJack and a new unipedicular curved balloon system.
Yes. Thank you, AJ. It's a privilege and honor to be back at the MedEd Combine. And Troy here is going to give us a hand, and we're going to talk about the Stryker SpineJack as well as the brand new curved needle.
Great. So we have, if you can see that okay, we have one of the slides up there on camera 4.
Yeah, you can see that. It's very tiny. So.
Yeah, we can make it larger.
Oh, there you go. Thank you for the
perfect.
As they get older, the eyes get a little bit worse there. That's why we wear loupes. So I think that what is SpineJack? It's a restoration of height and an ability to hold the fracture height while you're cementing. I think that we find it to be very useful in especially kyphotic deformity fractures where you want to lift and give good height. We've found it useful in trauma as well. Several sizes, and I think it just, as was stated by Dr. Jafrida, always important to look at your imaging and read your imaging and do your measurements, work with your reps to know which size is appropriate. And so it's one of the permanent vertebral implant systems. It's just like a little SpineJack. It's just a little jack and a scissor jack in a car to elevate the end plates. We found some excellent fracture reduction, also ligament ataxis, where you have retropulsion that pulls the fragments away from the canal safely. And so this just shows us that to assess the fracture, certainly you can refer to your TLIX scores for different types of stabilities and whether this needs to be used in conjunction with supplemental fixation or not. But looking at these fractures, I think that there are several imaging modalities on the MRI. The T2 stir sequence, which is a short, tall inversion recovery, shows the fracture as bright. We also correlate that with the T1, where it should be dark or hypo-intense on the T1. And that helps you guide which fractures are acute and which are chronic. And then it's a matter of targeting the level, and this shows a nice demonstration of how the lift is. There's been more than 100,000 SpineJacks done worldwide. Has a very good safety profile. But what I certainly like best about it is that there's significant less cement extravasation than when traditional vertebroplasty or even kyphoplasty. And the SACO study confirms that SpineJack system's superiority over balloon kyphoplasty to restore vertebral height and hold it, as well as reduce kyphosis and reduce stressors on an adjacent level by reducing that kyphotic deformity.
And that's something that we struggle with just simple kyphoplasty is we don't always get the height restoration we want. And sometimes there is that extravasation of cement that kind of stops, or you have to reposition your needles or try to do something different to stop that from going in a place you don't want it to go.
Very, very true. I mean, traditionally when we get our balloons in, we have an excellent reduction. Even trying to leave one balloon up and putting the cement in, the cement never hardens fast enough, then you take your other balloon down and you lose some of that reduction. I think we have had excellent height restoration here, and like I said, the new indications for trauma has been very helpful, as this has saved people from lateral base or anterior base corpectomies that would otherwise have gone through those more morbid procedures. Now we can do them less invasively.
That's great.
So I think that the next product up there is the Omni Curve curved balloon system. I think that what we'll do is, my plan would be to demonstrate, put all 3 trocars in, demonstrate SpineJack, and then we can demonstrate the Omni Curve. Full disclosure, I'm mainly a bipedicular surgeon. I feel that since we do a lot of percutaneous pedicle screws and pedicle screw placement, it's just a more natural thing for me. But for someone that doesn't need a lot of height restoration, or if you're doing an office-based kyphoplasty, that in patients that may not tolerate bipedicular approach, I think the curved needle and balloon system offers an excellent option. So adopt it to your practice. I think that you have a myriad of tools out there, and it's not a one-size-fits-all. You have several different products, from balloon kyphoplasty to unipedicular, bipedicular, and the SpineJack to choose from, and I think that you individualize that to each patient. And this just shows the new and improved sheath and access gun. We like the little access gun down here in Florida, showing that we can get with the nice beveled needle a more predictable crossing towards the contralateral side with less difficulty.
Yeah, and that's, I think, what has made unipedicular a little bit unpredictable and a little difficult to do in those patients that you didn't want to have to do a bipedicular approach. You don't always know if you're going to get that great spread across the midline and fully kind of cover the length of the vertebral body.
So true, and that's why I tend to gravitate toward bipedicular, because it's always very predictable in my fill. I tend to want to put more cement in there because I do think that you know, maximize the amount of fill, that also reduces the stress on adjacent levels as well. Go ahead. And so this just shows the different approaches where we have bipedicular and unipedicular, and you're covering almost same surface area.
Right.
So once again, this could supplant bipedicular use for some users. So I think let's get to the...
Yeah, let's go ahead and get started here.
So I think most importantly when you're setting this up, I always set up my own Mayo, and then the scrub tech will assist, but I always set up with any procedure, set it up in the way you're going to use it, whether it's this procedure or even epidural injection. I always set things up in the way that you're going to use them so that you don't skip steps or make any mistakes. So if you come to AP, please, very important to get good AP imaging and good imaging in general. If you don't have that, then it becomes very challenging. I think that you can, you know, have all eyes on deck when you're doing these procedures, whether it is in hospital, you know, is for SpineJack or office for kyphoplasty, to make sure that you have good pictures. So let's, if we could localize one of these levels here, please. So I think that if we can maybe see over, usually it's the wrong way first for me and then the right way. Go ahead. See, always the wrong way first. So there we go. And then if we can maybe do a little craniocaudal. There you go. So I think what we want to see is we want to see that nice, I call it the owl. Two eyes being the pedicle and the spinous process being the beak, and we want to see a nice flat end plate. So I usually will kind of mark the midline and take a shot again. And then know about 3.5 to maybe 4 centimeters right or left lateral midline for the SpineJack, because you want to triangulate them almost like a pedicle screw placement for the surgeons out there. For the pain physicians, you know, we typically, in not too obese patients, about 3.5 to 4 centimeters lateral midline. The more obese, the more lateral we go to get a better trajectory for that. So I tend to work a lot in AP. You can use 2 C-arms for this. It's certainly beneficial. We tend to see over with the lateral, because then when we tilt it back, we can go from thoracic to sacrum without having to have the AP hit that. So take a shot here, please. So right here, I tend to AP. We go down and I try to dock at maybe 3 o'clock position, and then with this AP. And I take it usually to medial border, and then we go to the other side, AP. AP again. And AP. A lot of times if you hit that TP junction there, you can't go any more medial, and it acts as a safety stop. And if you listen, it should be about 2.5 centimeters from the skin to where you get the medial border of the pedicle, where you're at posterior margin of vertebral body. AP. AP. And so then we'll do the other one here, just from some time-saving standpoint. If you turn the handles medial laterally, then you can put the subsequent trocars in at this additional levels without having too much trouble. AP. And maybe we could take a little bit out of the C over, a little bit out the craniocaudal. You take this one. That's good. See, take a shot there. Maybe back a little bit the other way. And AP again. I'll do it this side. AP again. AP. AP. Yeah, looks a little ugly.
So you prefer kind of, you line up everything and then you're measuring out from midline and then taking that approach to the 3 o'clock position?
Yeah, the 3 and 9 o'clock, it depends on what the anatomy of the fracture is. Sometimes you need to go a little bit different.
Okay.
Let's go lateral for a second, we'll see where that is.
Yeah, it's interesting to see the different approaches. You know, a lot of people also kind of open up the pedicle and then do a bullseye approach.
Yeah, you guys tend to want to do more of an en-face view.
Yeah.
So with the lower ones, you can see that we're already into the vertebral body, so we're pretty safe there. And with this one here, I think that I could do a better job with its angulation. Can you take a shot again? And so a lot of times when you can redirect. AP? AP again. And then what I will do is, AP. We can flip back to AP and then make sure that we're safe in the safe zone. As long as you don't cross the medial board of the pedicle, which hopefully we have not done, then you're in a safe zone to access the vertebral body. So I think we're right there, and so we can go back to lateral. And this is a fairly efficient way of doing it if you only have one C-arm, is to use the AP first, get to the medial board of the pedicles, and then flip lateral, and then you can for the upper technique right there, we want about posterior third of vertebral body. For the SpineJack, it's just the access the posterior quarter or so, because we're going to be dropping our guide wires next. And then, so much like if you've never worked over a guide wire for percutaneous screws, just having good wire control is paramount lateral. And so what we're going to do is we're going to get the wires in. I usually probably put them in
halfway up.
Yeah, at least halfway, 2/3 way. And then you want to add a little bit of downward pressure. Be very cautious with the wires, because some of the osteoporotic bone you can punch right through. So you really need to be very liberal with your fluoroscopy with these procedures. So then hold the wire gingerly, and just a twisting motion, pull back, will alleviate this. And once you see this at the tip of the skin, then grab the wire again and come on out. Similarly with the the other side. Lateral again. And similar motion. Next, we're going to use the drill and the upsize cannula, which will be our new working cannula. Coming down over the wire, backwards counterclockwise to get to the bone, and then clockwise once you hit the bone, lateral. And just follow the wire, and every few turns, lateral, you want to take a shot. Because you want to make sure your wire is not walking anteriorly. Lateral again. And this drill will measure how much your SpineJack can fit into the body and where your ultimate position will be. And lateral again. I think that looks pretty satisfactory. Lateral again. So once you have the drill out, and in this case you could also, I'll show on the other side how you can redirect if the drill wants to come out.
Yep. You get a nice core of bone out of this drill as well.
Right.
Yeah, there you get your bone
Make some
biopsy.
room.
Yep.
So then the template device, take a shot there. That just confirms that you can fit the SpineJack in, and then we take the radio opaque template, lateral again, where you just have put your marker up front, and then we'll repeat this on the other side. And Troy kindly has reloaded my drill. So counterclockwise to the bone, and then a clockwise motion here, lateral again.
And why do you do counterclockwise to the bone?
Just to get the soft tissue off.
Okay, gotcha.
Lateral again. And if my wire starts to walk, you can redirect it. Once see that the tip now is into the vertebral body here, lateral again. What we can do is we can pull our wire, and I can redirect lateral, and I can redirect the drill to a different trajectory if I'm not happy with it. Lateral again.
What kind of anatomy would you pick a SpineJack case for versus a traditional kyphoplasty?
I think if it's junctional, T12, L1, if I know, and they're in a lot of kyphosis, I really think the SpineJack is a better option. If there's an element of burst fracture that I want to pull this fragment in, that's another good indication for that. Or if there are even some of the lower lumbar levels that you want to make sure you're really restoring lordosis there and height. Shot?
How much retropulsion can you fix? Sometimes that'll that'll be a difficult case to do as a traditional kyphoplasty.
I think that's as the neurosurgeon we set some of our cases up for that if we need to do corpectomies and if we have all the instrumentation, so we have options available to us that some may not have. And so I think that we've pushed the envelope to 25% retropulsion with good success.
Okay, great.
And so I think it can be done. You just have to trust your neuromonitoring. Remember and look and see what their preoperative deficit. If they have 25% retropulsion and no neurologic deficits, I think, and it's in L3, then I think that's safe. Like I said, in the thoracic spine, you have to be much more cautious, and I'm not sure I would do that in the thoracic. I think you're much more leeway in the lumbar spine where you're dealing with the nerve roots.
Right.
Exactly, but I think you just have to make sure that you know what you're treating and you have options to bail out.
Absolutely.
And so in this case, I've gone away from taking APs. You probably should just take an AP to make sure that the bottom of these implants are perpendicular with the horizon, just so that you have the SpineJack in the proper orientation. Take a louder. And then let's go, if we could just take an AP just to make sure we're happy with our SpineJack placements. You kind of want to triangulate them to give the most lift, because we will cover a lot of the end plate, and in the triangle you have a good symmetric lift to allow for that. So I think that's satisfactory. You just don't want them divergent or parallel. I think the more you can triangulate them, the better. I think you go back to lateral, please.
Do you want to fill the cement on both of them at the same time, or mix cement now for the SpineJack?
I think we could probably just do this one at a time. Maybe.
Yeah.
And so then what we'll do is we'll start taking some turns on this. Louder again. And this is where, like I said, you want to take some shots, frequent shots. Hold the handle so you don't rotate the implant, and you'll feel the implant expand. And the benefit of the implant with the skis, or the top and the bottom, they will deflect. We have not had any of them plow the end plates. So we've pushed the envelope pretty strong on them. Lateral. We may not be able to get as much expansion in this type of bone, but we'll try. Lateral again. There we go. Hopefully we don't break things too much. Sometimes, even though,
It's a pretty tough model.
I train with enough orthopedic spine surgeons as a neurosurgeon that sometimes we just get a bigger hammer.
That's right.
Lateral again. So there we go. See how we're getting a little bit of lift, and you can see some deflection. And this is a lot of a feel technique. There's no right or wrong answer on how much you expand. Over time, you'll get a feel and vision and feel. A lot of the kyphoplasty access is by feel. Lateral again.
Sorry about that.
So once again, I think a lot of the access is by feel, and there is a stopping point for these. I mean, many a times when you're even accessing the pedicles, you hear a very hollow sound when you're getting through the cancellous bone, which is the right place. If you hear a high-pitched sound, that means you're at a cortical wall, and that's why it should give you some pause. This is the biggest pain of the device, so I'll hold this, and you turn the big one backwards as many times as you feel comfortable to save the torture of turning the little one. And usually this takes forever to get these disengaged, which is the most annoying part. So. And usually one side will disengage faster than the other. But
Well, that felt like a long time.
Yeah.
But it was only 30 seconds.
30 seconds.
Right,
to
so
mix
it's
cement.
pretty quick.
Yeah, the work
that's
time's about
pretty
18 minutes. In a long 30 seconds.
Now, Dr. Stryker, you were talking about trauma cases that recently have been approved for SpineJack, where you used to have to do a corpectomy on them. Can you talk a little bit about those types of cases?
yes, I think that some of the fractures that have had ligamentous injury that we might, otherwise, do corpectomy on. Especially some of these patients that are elderly and you don't want them under anesthesia a long time. You don't want to have, minimal blood loss. I think it's a good option. Once again, the beauty of spine is that there are many ways to treat pathology, and there's different ways, and many of them are not wrong, and I think you just have to adapt to what your comfort level is and what technologies you have available, and then you have bailout plan. I think it's important to, if you're planning on this, have the corpectomy cage available, have your lateral or posterior access retractors ready, and you can convert it. Like I said, it's just as long as you're doing it safely. Even if you had the device in and you weren't happy with it, you can certainly do a corpectomy and take it out. It's still,
right.
But I think that certainly we recently did a L3 fracture, in an 85-year-old with 6 little incisions and 10 ml blood loss, and about an hour or less of operative time, then did very well, even with retropulsion. So I think that's great. And we cemented our screws in. So
if it ever gets stuck, you can clamp this on and tap up on it. Yep, you're good. Perfect.
As you can see,
Yeah.
pure torture.
You're right. How much time did that save you on that case? How'd you have to do the traditional methods?
Yeah, I mean, you're looking at several hours for corpectomy and possible position change, and so lateral again. So this is just, very slow, and the benefit of the cement that we find from Strykers is much thicker, and like I said, that you'll have less extravasation. Lateral again.
Will this hold about the same amount of cement as, say, a balloon, or?
I think you find we'll have a little bit less cement sometimes because the device takes up some room, but all in all, I think you'll have a similar fills pattern.
Okay. While we're working on this, do you want to deploy the balloon here?
There you go. Sorry, reaching over you.
No. Yep.
And like I said, just fill to your comfort. Just make sure that when you're filling, just take frequent pictures to make sure that the cement is not going somewhere you don't want it. And at the end of the day, if you look at the literature, you could have 80% extravasation somewhere. The only time we don't like it is posterior. So
Right. Right, posterior and vasculature, right?
Yes. Posterior and PEs are never a good thing.
Right.
Is there a certain percentage height loss that you look at the SpineJack if the body's 20% collapsed or 30 or?
I think you have to have at least enough to get the device in.
Gotcha.
And then that comes into play is, do you want to try to balloon to get more height level to get the device in or not? And that's sort of people's comfort and decisions. But I think that if the height of the vertebral body is not enough to get the device in, probably just traditional kyphoplasty with lateral. So I think in the effort of saving time, we won't fill the whole thing up.
Yeah, no, that's looking great. It's going really well.
Next one, once you get that out, just take the inner cannula in and just tamp down to here metal, syringe motion, and pull it out. And syringe motion and pull it out. So now we can do the other level.
Yep, so this is the Omni Curve balloon. It's our 2nd generation curve balloon. So the first thing he'll access, as he already has, then he'll use the introducer sheath. This is the biggest change between the 1st generation and 2nd generation curve balloon. He brings it until it's flush with the first laser etching.
And then the arrow points medial. And then what we'll do is we'll use the mallet.
You'll clamp the, yep.
What we're going to do, we'll squeeze this here to deploy.
Yep, this is stainless steel instead of nitinol. A little difference from the first one.
Lateral, please. And then we'll start doing a tamp. Lateral. And then I'll take it to the first line here, and then we can check an AP and see what. Go ahead, AP, please. And then we'll see where we're at, and see if we need to go further to the contralateral side or not.
You don't need as much of that elastic memory. That's why it's
I think we're
stainless
far enough
steel.
over there, and then we'll disengage this.
Yep, you release the tension on the gun.
Is that the reason to go stainless steel over nitinol? Is that memory isn't as necessary?
Correct. Yes, and it can get across,
Go that
so
on
a little
gonna be a
bit
little
easier.
stiffer
And there's a bevel tip on this, and there used to be no tip, so it goes across the bone a little bit easier.
And since I was a little far, I did pull this back a hair.
That's fine. Yep. So take the sheet off. This is a 30 millimeter balloon. It comes with a 15, a 20, and a 30, depending on what vertebral body. He's going to flush up the hub.
And then the syringe maneuver to pull it back further. And take a shot there. And then we can start.
You need to push your balloon a little bit further. You can press that little gray button there. So push gray button on the top of the white piece there. Yep. That one. And then push the balloon down. Anterior. Good. Yep. So you push that button in, and then you push that. There you go. There you go.
So then we'll expand the balloon a bit here.
Yep.
Lateral again. Lateral again. And that's why we take an AP just to make sure we're happy as well. Maybe a little far to the side there, but we'll check it out for us. I think we'll let the balloon down now a bit, but I think that in general I would probably maybe pull back my sheath a little bit to maybe get a little bit better.
Right.
So maybe we can do that as well to try to salvage.
But you can see how far the reach is. You can definitely get it to reach far enough apart.
Yeah.
So
Sorry.
that's okay. I think we're far actually.
Yep.
Yeah, I think we're good.
Okay. Not good, though.
So then you would zoom out and then fill as you would normally fill.
Yep, fill that, or through the curve needle, however you would know fill.
Okay. Yeah, but I mean, it's pretty impressive how far it can get across that level in one
The
shot.
reach is significant.
Yeah, it absolutely is.
Really, and this is almost better than bipedicular because you really can pull back, reinflate the balloon, and come back and adjust a bit if you want.
Yeah, this is good.
Let's do that AP one more time, please. And you can see we made a heck of a cavity there all the way to the other side.
Oh yeah,
You can
absolutely.
really take a look at that cavity. So.
Yeah.
So, you know, like you saw in the slides, you really can mimic very closely what you do with the bipedicular approach with one entry. Yeah, it's really nice.
You might be converting me.
On air.
On air
conversion.
it's tough. It's the old dog needs to do new tricks here.
If you want to fill, you can, Doc. So there's two ways to fill. You can fill through the sheath, or traditionally through the nitinol needle, which will allow you to reposition a little bit easier. So
As long as you don't get it all over to AJ.
No
Yep.
worries.
So we can.
I have to walk.
You take an AP there. AP again. So since we were a little far to the other side, I'm not going to deploy this as much from when I'm filling. Take a shot. And I'll allow that fill to catch up, and then I can move back with it. So some things, like I said, just be smooth. Not everything goes 100% perfect, and then you got to be able to adjust on the fly. AP. So now that I see that, maybe we'll pull back a little bit just to make sure I'm not pushing more out in case I went through the other side.
Stay central.
That again. And see, we're getting a little bit there. So if that happens, we'll just wait for it to harden up a little bit and come back. That again. And then we can keep with our fill. That again. And now you can see we're getting into the center.
midline. Yep.
That again. But just once again, if you get a little extravasation, the key is not to panic. As long as it's not posterior and you have no changes in your neuromonitoring, take a breath. Go to the other. If you're doing bipedicular, go to the other side, work a little bit, then go back to this. Or even if you have a balloon, to eggshell it. And but just it's not a freak out method. Just take a breath.
Pause,
Take a breath.
reposition.
Pause.
Yep.
Little time.
This was great. This was fantastic. I love how you guys were able to squeeze in 2 SpineJacks and a kyphoplasty in one half-an-hour segment.
Yeah.
That was really impressive.
AJ, always
Thank
a
you
pleasure.
very much.
Thank you so much.
If anybody wants to get in touch with you guys, wants to get trained on this, how do they get in touch with Stryker and learn more about this system?
Well, I'm Troy with Stryker. I'm Dr. Slipka's rep, territory manager in the Palm Beach County and also up in Martin County. So yeah, go ahead and either call me at 315-391-3209 or you can email Troy Zelasco at yahoo.com.
If you can spell Zelasco.
Yes, Zielasko, but yeah, you can go ahead and get a hold of us or call the 1-800 number customer service and they can go ahead and connect you with us as well. So thank you.
Thanks, guys.
Thanks, guys.
Thank you. Nice seeing you again.
Great.
Thank you, sir.
Great job.
Pleasure.